We present to you a video of ultrasound-guided hysteroscopy following endometrial ablation. This video will demonstrate simultaneous use of pelvic ultrasound and hysteroscopy to access an ablated endometrial cavity. Endometrial ablation is commonly used to treat abnormal uterine bleeding. It frequently causes distortion and adhesions of the endometrial cavity and cervical stenosis. As a result, this can create a challenge in accessing the cavity for endometrial sampling and reoperation. Studies have found an endometrial sampling failure rate following ablation of 23 to 26%. We present a case of a 60-year-old gravida 2, para 2 with post-menopausal bleeding. She has a history of a global endometrial ablation 12 years ago with benign endometrial biopsy at the time of ablation. She is otherwise healthy and has never had other surgery. Pelvic ultrasound demonstrated an endometrial thickness of 5 millimeters and no other abnormalities noted. An office endometrial biopsy was attempted but was unsuccessful. Ultrasound-guided hysteroscopy with endometrial sampling was then discussed. She provided informed consent and was then booked for the procedure. A 2.9 millimeter operative hysteroscope with a 30-degree lens was selected. A skilled assistant provided ultrasound guidance during the procedure. Ultrasound was used to delineate the tract of the endometrial cavity to reduce the risk of uterine perforation. Dilation was not necessary to enter the cervical os. If difficulty with dilation is encountered, a cervical os finder or mini cervical dilators can be helpful for a stenotic cervical os. Normal saline was used as distension media. Hysteroscopic hydrodissection was utilized to expand the endometrial cavity for better visualization. The lower uterine segment was found to have dense adhesions. Under ultrasound guidance, gentle blunt dissection was performed using the hysteroscope. A hysteroscopic grasper was also utilized to gently dissect the adhesions. Once space was created, the hysteroscope was advanced slowly. Good visualization and slow, subtle dissection are essential. The endometrial cavity proximal to the ablated tissue was then entered. Sampling was able to be performed. We present to you a video of ultrasound-guided hysteroscopy following endometrial ablation. We offer these surgical pearls to increase your success at ultrasound-guided hysteroscopy. A skilled assistant is essential to perform ultrasound for procedure guidance. Cervical stenosis can be overcome with a cervical os finder or mini cervical dilators. Hydrodissection with the hysteroscope is useful in dissection of adhesions and improves visualization. Gentle blunt dissection with the hysteroscope or hysteroscopic graspers can be achieved with slow, subtle movements. Optimal visualization is essential throughout the procedure to reduce the risk of uterine perforation or false passage creation. In summary, ultrasound-guided hysteroscopy in a scarred and distorted endometrial cavity is safe and cost-efficient. It facilitates access to the uterine cavity and prevents false passage and uterine perforation, particularly in the case of previous endometrial ablation.